The FPQC is proud to have the director of the California Perinatal Quality Collaborative, Jeff Gould, here as one of our key speakers at the annual conference. Jeff has dedicated himself to more than 40 years of improving health outcomes of mothers and infants through data-driven quality initiatives. Dr. Gould, as a neonatologist and epidemiologist, is known today as one of the most highly regarded leaders, researchers, educators, innovators in the field of maternal and child health. In 2006, he received the National Epidemiology Outstanding Leadership Award for a significant contribution to the field. Not only does he know how to do it, his ability to lead others in that direction. As the director of FPQC, Dr. Gould currently oversees a network of 124 California hospitals that conduct quality initiatives for mothers and their newborns through voluntary submission and comparison of uniform care and practice processes and outcomes. FPQC is recognized as the most established perinatal quality collaborative in the nation today, with over 10 demonstrated quality improvement toolkits, with many more on the way, one including protocol use on antenatal steroids. The way I think of Jeff is one of those dream makers. There's some people who can dream those dreams of what we need to do, and there's some people who can just make things happen. Jeff has been one of those unique individuals who has created dreams that none of us thought were possible and made them happen. And if you know Jeff, the dreams don't quit. He can tell you about the next dream that he's working on, and it's done an outstanding job of setting the leadership for the field and what all of us need to do. And I hope that we're only 10 years behind you, Jeff. We welcome you to support us.
Gee, what a terrific intro. I wish my mom were still alive to hear that. We've been very lucky, actually. So we're going to talk, I'm going to talk about collaborations, and then at the last part of the talk, we'll talk specifically about antenatal steroids. It seemed to me that perinatal medicine was really, when I started certainly, and even now, in many instances, seems like a series of handoffs. You know, the obstetrician does their job and they hand it off to the neonatologist, and the neonatologist does their job and they hand it off to the developmentalist, to the community pediatrician. And it really is like these separate, I guess they call them silos now. But you know, there are some pioneers that really started to break down these silos. And Virginia Apgar was the first one, and she was an anesthesiologist, and probably everybody knows that the reason she invented the Apgar score was just to look at the baby, period. You know, she didn't really care about prediction and all this stuff. But what would happen is that there'd be a delivery, the baby would be set in the corner, everybody would attend to the mother because, you know, that's what obstetricians do. And then what about the poor little baby who was in the corner turning blue, maybe not breathing, etc. So the Apgar score and this whole movement was really to start to bridge the gap between neonatology and obstetrics, to start to pay some attention to the baby. Dr. Hahn, invented, I guess invented is the word is okay, fetal monitoring. And again, all of a sudden, obstetricians were starting to think about the fetus, and neonatologists were starting to get excited about this. Dr. Holmes invented heart rate monitoring, ultrasonography. And then Lou Gluck came along with the LS ratio to look at lung maturity. So even though there was the obstetric box, there was this concern about the newborn and in the condition of the newborn that was developing. So there were pioneers to try to break down this idea of handoffs, a series of handoffs. So what's the rationale for a perinatal approach? And I think one of the rationales is that neonatal outcomes are heavily dependent upon prenatal and perinatal factors. And they're not just heavily dependent upon, but there are some areas that are that are absolutely important. The use of antenatal steroids that we'll talk about, promotion of breast milk. You know, in hospitals where promotion of breast milk is just a neonatal thing or a pediatric thing, it just doesn't fly. You just can't do it. You know, one of the most important parts of promotion of breast milk happens when the baby is born, bringing breast to the mom right on the delivery table. What happens during on the obstetrical side is really crucial. Even promoting breast milk, you know, a null-lip mother may meet with a pediatrician once, but will meet with the obstetrical team throughout the course of her pregnancy. If that obstetrical team is talking about breast milk and getting things started, absolutely crucial that you cannot have an effective breast milk program without the involvement of obstetricians. In fact, I think obstetricians and lactation counselors are the key to this, and I'm never sure which one's more important, probably co-important. Neonatal input can optimize help optimize the outcomes for both a mother and infant, and one of the things that are emerging are combined high-risk fetus rounds, where obstetricians and neonatologists are meeting with the family to try to talk about what's going to happen and help with decision makings when there are difficult issues arising. And then the common goals for obstetrics and neonatology can really be facilitated by close collaboration. And again, when obstetricians and neonatologists work together, they can reinforce health education objectives such as with breastfeeding. But they can also present a united front with respect to administrative issues. If there's something that has to be changed perinatally, and both the head of obstetrics and the head of pediatrics go to the administration, you're likely to be listened to more than if it's just one or the other. And oftentimes one or the other, I've heard, play off against each other. You know, the administrator, oh yeah, it's important to you, but I've spoken to my colleagues in obstetrics and et cetera, et cetera. So I think a united front is a really important thing. Well, I love our first talk was just so spectacular when this sentence, which I will steal forever. Of course, in quality improvement, you don't call it stealing, you know, it's kind of like sharing. So I'll share forever that what gets measured gets managed. And it's really important. Anytime you think about perinatal approaches, you require data. So I want to first talk a little bit about data. Data allows you to ask a couple of questions. It asks you to allow, you know, what do you need to improve? If you don't measure, you don't know. We were talking this morning at coffee about transport, and one of the things in neonatal transport is if it's an acute transport emergency, you're out the door in 30 minutes. And in California, everybody agreed that for these hot transports, just about everybody was out the door in 30 minutes. And when we measured it, it was about 30% of the time with a really acute transport need were we out the door in 30 minutes across California. So if you don't measure, you just don't know what you need to improve. If you don't measure, you don't know exactly what to do to improve, because, you know, like you may have an idea that something isn't working, but if you don't measure exactly what it is that you're doing, it's very hard to know what part of what you're doing needs to be changed to improve. And then once you institute those exchanges, if you don't measure, you don't know whether you're doing progress. So this idea of control charts, this idea of plan, do, study cycles, these rapid little cycles, really require measurement to tell whether what you've instituted is actually working or not. So data is very, very crucial. So I want to give a couple of examples of data that we have found to be helpful. So one of the things that we looked at in California was the time of birth and the risk of neonatal death. And the reason that we did this is that anecdotally, people were saying that things were tough if you were born at night. And we wanted to look at this and say, well, was that kind of true or not? And so the aims of the study were to figure out whether there was a relationship between the time of birth and the risk of neonatal mortality, and also to look at the possible contributions of fatigue and impaired structural capacity. So fatigue is kind of easy to understand. We look early in the night and late in the night and see later in the night are things worse than early in the night. If they were, then it's probably fatigue. Structural capacity is a kind of an interesting thing, and we all know that at night there are a lot of changes in the structure. You know that oftentimes in the NICU, who gets the night shift? Oftentimes the night shift is rewarded to some of the youngest and most inexperienced, whereas the really experienced nurses get more of their pick of where they can be, and so night is usually pretty thin, pretty inexperienced. That's where you have to call in people that are at home oftentimes, and especially in smaller units. So we wanted to look at this as well. So this is an old study. We looked at about 3 million births. California is pretty unique in that we have 500,000 births a year, so that it allows us to do studies that can't be performed in some of the smaller states. So we looked at over 3 million births. We built these models to adjust for case mix, really important because we know that at night a lot of women that are really in trouble come in at night on an emergency basis. So we had to adjust for that. And we compared daytime to early night and late night, controlling for initiation of prenatal care, complications of pregnancy and labor, congenital anomalies, gender, birth weight, all of those things that could have given you a false impression of what's going on. And here's the chart that kind of shows what's going on. I think it's pretty self-evident. Here's if you average mortality for the whole day, it's this line here for the 24 hours. And you can see during the day mortality was kind of low. And then around change of shift, in California, change of shift is not standard. It probably isn't standard any place. But you can see around change, all of a sudden, whammo, this mortality goes up. And this is after controlling for all of these case mix things. So case mix being controlled, all of a sudden things go up. And the interesting thing is that they really stay up all night. So they don't get worse than late night, suggesting that it's probably not fatigue that's going on, although there may be some fatigue, but it's really probably the structural capacity of the units that are changing, that are going up. Really very, very dramatic change. We looked at causes of death, and in most of the causes are more in the obstetric domain. Asphyxia, there are several publications now that have kind of confirmed this. Asphyxia really goes up. Obstetric conditions go up. The neonatal infections and some of the perinatal infections, respiratory distress, the kinds of things that we see in the NICU don't particularly go up. So it seems to be mostly the obstetrical side that's where the challenge is at night. So the interesting thing is that infants born at night across California had a 12 to 16% increase in neonatal mortality rate. And this excess accounted for about 9.6% of all neonatal deaths. And so identifying the causal factors and reducing the increased burden of mortality should be a major priority. And I have to say that after doing this, we did the standard academic thing, and that is we published the paper and forgot about it. So this is an illustration of non-quality improvement strategic stuff. You know, we should have really done something about this. And I was thinking as I looked over my slides last night, maybe it's time to look at this again to see if anything happened. Well, what happened? After publishing this, people from around the country called mostly obstetricians, they said, well, we know, oh, thank you for publishing this paper. We know this has been going on. We've gone to our hospital administrators. No one's ever paid attention. Now that we have this data, maybe we can get some traction. So one of the things that we probably should do in California is to see whether publishing this paper alone did anything, or whether we're still in the same boat that we were several years ago. So this is an important, this kind of little study illustrates a couple of important things. The first thing is that if you don't measure, you don't know what's going on, and you don't know the extent. If I had a pill that could reduce neonatal mortality by 10%, I could have a disclosure thing and make a lot of money, you know, and people would jump right on it. They'd jump right on it. But here's a structural thing that's going on. That's 10% of neonatal mortality probably could be eliminated if we paid attention to how we staff at night, to how we do things at night. And so I think that the first lesson from this is that it's kind of important to look at data, absolutely essential. The second is that you have to have action. If you're talking quality, data is only the first step. You know, knowing this is the first step. And I feel so embarrassed. I mean, I really feel embarrassed at this time to come to a group like this, present something like this and say, and we did absolutely nothing about this formally. So this is a great illustration. You collect data, but that data has to be transferred into action. But I did this a long time ago, you know, so I was young, I didn't understand these things. The role of perinatal advocacy is really important because what it means is that now with this data, both the obstetrician and the neonatologist and pediatrician can go to hospital administration, show them this data and say, hey, look, we have to do something about this. So combining, collaborating in terms of perinatal advocacy. And I know that there were many places around the country where this actually happened. The second thing I want to talk about is an example, these are kind of data examples, of linking birth certificate in the universal billing. And it's wonderful that we had that wonderful talk this morning because we learned about the linkage of clinical data, hospital data, linked birth certificate with the universal billing form. The universal billing form is where you get your ICD-9 codes, and in the hospital has that. So we decided to look at elective delivery of early-term complication-free singletons. This was kind of in preparation before we started to do the toolkit. We wanted to look at the situation in California to see what was going on. And in this very important because here's a chart and it shows elective deliveries and complication-free deliveries and of the complication-free deliveries, which are in blue, what percentage of elective deliveries, which are in red. And in order to do this, you have to combine two data sources. You have to combine the infant birth certificate in order to get gestational age, precise gestational age, because it is not on the universal billing form. Our universal billing forms go to the Office of State Health Planning and Development, that's OSHPD. They put the files together. So if you get an OSHPD file from that, you can get complication-free deliveries by looking at all the ICD-9 codes and the procedure codes, and you can put together this measure. So I wanted to just show you that this is a measure that requires the linkage of birth certificate with the ICD-9 codes. Now, in the old days, sometimes it's important that you prove for yourself that what is said to be important actually is important, and sometimes you can use data that's already been collected. In Japan, they had done some studies years ago on antenatal steroids, and it looked like in Japan antenatal steroids didn't do very much. And so they used this as an excuse not to really promote antenatal steroids. And we worked with them, and they sent us, I don't know, 10,000 records, and showed them that actually antenatal steroids in Japan were really important. And this led to the promotion of antenatal steroids, et cetera. So sometimes it's very, very important that you prove the concept or prove the importance of doing something with your own data. But sometimes to do that really slows the process down. So we felt that there was enough indication that early elective delivery of term infants was not a very good thing to do. So we just pre-packaged rather than doing it ourselves. We pre-packaged the rationale, and here's some of the rationale. People are probably pretty familiar. Probably pretty familiar with this rationale. So here's elective inductions and here are the dates. And it's really important that you talk about never use 37 weeks. I get so confused by what do they say when it's 37 weeks. It's 37 and 0 to 37 and 6/7. So it's very important when you're talking about people. And I thought the first talk today was so clear about when we say this, we're talking about 36 and 6/7, you know, that to really talk about, never use these terms 37 weeks or even 37 completed weeks. You know, if you can use the way we're doing 37 plus 0, 37 plus 6, it's really much easier to understand. You'll never really appreciate this until you have to explain it to someone, and they say, what do you mean by 36 weeks? And you say, what do I mean by 36? Is it 36? So very important to use this kind of thing. But you can see that over this very short period of time, really dramatic changes in elective to the NICU, whether it's elective Syrian or total elective deliveries, huge differences. And then if you look at you know, length of hospitalization, sepsis rate, respiratory outcomes, everything that you look at, very, very sensitive to this. So this is the rationale, and I think that before you ever embark upon quality improvement, you have to convince yourself that what you're embarking upon really is going to improve the condition of the mom or the baby. Because if there's no real proof that what you're doing is going to be beneficial, then it's really hard to convince people that they should be doing this. So methods, complication-free term births. We looked at singletons. We got our gestational age in singleton from the birth certificate. We got our Joint Commission list of ICD-9 codes. Whoops, sorry, I keep doing this backwards. For elective, we looked at the ICD-9 codes, and again, from this morning, this is probably just pretty clear how we did this from this morning's talk. And in California, so we looked at 138,000 early term deliveries, and we found that there were 14,000 inductions, that's 10% approximately, and in almost 50% of those, there was no medical indication for those inductions. And in terms of C-sections, there were 48,000 C-sections, again, of these early term deliveries. And in 31%, there were no medical indications. So it's really important that you can see that it's a really big problem, that as we're looking at these total term deliveries, there are both, there are a lot of spontaneous early term deliveries, but there were a lot of inductions and a lot of C-sections. And of those inductions and of those C-sections, there were many without medical indications. So in the olden days, you know, in a paper, you could just, you know, put that down and people would say, oh, that's really something. But you really have to relate that to the previous slides, because every one of those infants that has been inappropriately delivered is going to have a higher chance of going to the NICU, is going to have a higher chance of a prolonged hospital stay, is going to have a higher chance of sepsis, is going to have a higher chance of respiratory problems. And these are not trivial things. You know, if you think yourself, would you want your baby to be in the hospital on a respirator needlessly? I mean, so again, when we're doing quality improvement, we also want to know the numbers, but we want to be able to link those numbers to consequences, avoidable consequences, with tremendous meaning to the baby, tremendous meaning to the family, and hopefully tremendous meaning to us in terms of really promoting, preventing these kinds of things. So in California, if we look across 253 delivery sites, you can see that there's huge variation. And the reason I want to show the slide that there's huge variation is that when there's huge variation, that means that the possibility of gaining from a formal quality improvement is really quite great. We also looked, because of the public health perspective, we also looked at counties to say where there differences across counties. And this is very important because oftentimes what's reported you know, to the feds are your total measure for the whole state. And your total measure for the whole state may look quite reasonable, but it's an average of places that are doing quite well and places that are very challenged. And you can see across the counties in California, there's really a huge amount of variation. And the interesting thing is that in some counties, the variation is due to C-sections, and in some it's due to inductions. And there's no real relationship between C-section and induction. It just, for some reason, some places have more induction. Induction has to be reduced. In some places, C-section has to be reduced. So it's kind of an interesting. I'm a little colorblind, and I put this in this because I thought this was kind of this fiery red was kind of important, you know, and so rather than just have a bland color, I wanted to have a color that kind of suggested that this was a burning issue, you know. But being a little colorblind, I'm not sure whether this is burning or not, or whether it's just awful. The quality improvement challenge is really threefold. You have to have data. So part of the challenge is to collect high quality, reliable data. But just having the data it's not very important. You have to really take that data and present it as information. And information means that you have to have risk-adjusted reports that are readable, where you don't have to kind of like, oh, it's on page 3, your outcome's on page 3 hidden down in this. You really have to pay a lot of attention to being risk-adjusted. Why risk-adjusted? Because the first thing you'll get is, oh, the reason we do that is we have so many very severely ill neonates or severely ill you know, moms, and that's why our rates on this or that are so high. So it's really important that you risk adjust so that people can, risk adjustment is really important because you'll get an expectation as well as an observed, and we can say, yeah, we know you have really difficult patients. Look at your expectation. Your expected rate is so much higher than the state average. Yeah, you really take care of very sick patients, but gosh, you know, look at your observed. Your observed is so higher than your expected. So even though you're taking care of all of these really difficult patients, your observed far exceeds your expectations. So risk adjustment is really important. But even after you have the information, so now you've collected great data, now you've put the data in a format that makes sense to people. So the third thing is that what are you going to do about it? And it's kind of like illustrated by the first thing with that length of the deliveries at night. I mean, what's the action? So not only do you have to have data information, but then you have to have action. You have to be able to support your providers in their work of improving perinatal care and outcomes. At a minimum, you need a toolkit, but then you need support structures around that toolkit, actual organized quality improvement. So here's, that having found that we had a problem, that we were really interested in partnering with March of Dimes to develop a toolkit that was talked about, on elimination of non-medically inducted deliveries. This is a pretty good toolkit. I suspect a lot of you have already seen this. But again, this is the final phase, and it's not really the final phase. This is kind of like the semi-final phase. The next thing is to get everybody together to actually use this toolkit and to support them as they start to develop programs to incorporate the suggestions in the toolkit. Well, that's kind of an introduction on data and on action, and now I want to switch to a slightly different topic, and that's the use of antenatal steroids in women threatening preterm delivery. I think this is going to be sweeping the country, especially now that it's a joint commission. It's a joint commission metric. So, a brief history of antenatal steroids. Liggins and Howie discovered antenatal steroids. And the interesting thing was, one of the things at Stanford is that we're interested in prematurity, and we have a March of Dimes Prematurity Center. And one of the things that we wonder about is the role of the fetus in preterm delivery. Is the fetus somehow signaling the mom in some way that it's time to deliver? And Liggins and Howie back in the late 60s were actually looking for fetal signals to initiate labor. That's what they're in. So in their animal models, one of the signals that they were looking at were steroids, and so they were giving steroids and looking at steroids, and lo and behold, they found that animals that got steroids had a maturation of their lungs and less respiratory problems. They actually did a really good randomized control trial in 1972 and really showed that antenatal steroids were really of benefit in reducing respiratory distress syndrome in neonates. And then things went along, and by 1990, Crowley et al. Did a meta-analysis, and there were many randomized controlled trials that showed that steroids were really, really important. However, there's almost no acceptance. I mean, it went from, the highest acceptance around 1990s was about 34% of moms who would qualify for getting antenatal steroids actually got them. So this is really surprising until you realize that the average time from the discovery of a really important issue till its incorporation in general use is how many years? Anybody got a guess? 17 is what they're saying. So you get a really blockbuster breakthrough, and it, a blockbuster breakthrough, and it makes the New York Times, and it's on TV. Well, nowadays, I guess in the old days it wasn't, but everybody was talking about it, and it was the highlight of scientific meetings, and everybody's doing, so money's going into research, everybody's researching and doing more RCTs and looking at this and looking at that. And then 17 years later, it's incorporated into use. I think with the quality improvement initiatives going on, this is going to really change. But anyway, the first NIH conference was in 1994. ACOG endorsed this, and at that time they said that, there were 15 trials that showed decreased RDS, IVH mortality between 24 and 34 weeks, and we're not doing it. So that was in 1994. The National Quality Forum in 2008 adopted this. ACOG in 2011 updated their recommendations, and they were saying that between 24 and 34 within 7 days. It's a little bit different. It's really between 24 and 32 with ruptured membranes, and then 32 to maybe 34 if you have evidence of pulmonary immaturity, to give dexamethasone or betamethasone. And they also have a rescue recommendation. And then we heard about the Joint Commission adopting this this morning. So that's kind of a brief history of this. The current status, the Cochrane Review of Meta-Analyses, there's just incredible information that this is the right thing to do. Of course, there are unanswered issues, and there are several recent papers addressing unanswered issues. Should you use betamethasone or dexamethasone? Really unclear. What about the use prior to 24 weeks? There are several papers. The Japanese have just come out with a paper showing that they feel that it's useful under 24 weeks. What about after 34 weeks? So these are controversial areas. And what about a repeated or a rescue approach? So it's pretty clear that repeated is probably not the best thing to do, that the most reasonable approach is a rescue approach. And if you go on ACOG and look at their 2011 recommendations, they explain how that works. It essentially is if you have someone under 34 weeks and it's been a week since you've given the it's been a week since you've given your last dose, and it looks like the mother's going to deliver within several days, it's worthwhile giving a repeat. So this idea of a rescue is different from just a repeated dose approach. So again, the details of that are in the ACOG recommendations. So antenatal steroids, I think, is a really important quality improvement talk. It's important because of its impact. Most studied, it's probably one of the most studied and effective interventions to improve preterm birth outcome. There are evidence-based practice guidelines and over 40 randomized controlled trials that pretty much follow the ACOG practice guidelines. It's a vetted measure. There are 2 nationally used measures with experience in collecting and reporting. We heard about that a little this morning. And there's huge variation. There's a large demonstrated gap in care variation and in improvement. So it really is just a perfect kind of thing to look at. And the Cochrane Library on Antenatal Steroids shows it doesn't increase the risk of mothers of death, choriamnitis, or puerperal sepsis. The overall reduction in neonatal deaths about 31%. RDS is reduced 34%. Cerebral vascular hemorrhage 46%. Necrotizing enterolitis they feel is 54% reduced, and intensive care is about 20% reduced. So it's a huge advantage to giving these moms antenatal steroids. So one of the first, when we started the California collaborative, we had to pick a first quality improvement initiative. And we were both naive and lucky. I guess we were kind of, our choice was kind of, we wanted low-hanging fruit, and so we wanted to go after something that we knew that if you did it, you'd make a tremendous impact. But we also were very naive in that we were mostly an organization of neonatologists, although the executive committee had tremendous input with perinatologists. We had Kim Gregory, Lisa Korst, Elliot Main, who are real luminaries in pioneers in the maternal fetal medicine. So they were on our executive committee and kind of pushed for this as well. But what we didn't really take into account is that we were proposing a quality improvement initiative to neonatologists who would then have to act as change agents to get their OBs to change. So this is a real collaboration, and it's a kind of a gutsy thing to do. And we were so naive at the time, we didn't realize the chance we were taking. I mean, we really, but we were also, because on our executive committee we were perinatal. I mean, we had these hardcore, very very advanced maternal fetal medicine people as well as neonatologists. So we were functioning as a perinatal quality care organization out of those silos, and somehow the reality of the world escaped us. I mean, we really, had no. When we thought of doing this, we were so into it, we didn't realize that it was the poor neonatologist that was going to have to convince at their hospital level the obstetricians to go along with this. If we had thought of this out clearly, we might have not done this, because we might have been afraid that we wouldn't be able to do this. But, being naive, beginner's mind is always good, and so that's what we did. We looked at our Vermont-Oxford, because we're kind of an outgrowth, a regional outgrowth of Vermont-Oxford, and we looked at our Vermont-Oxford numbers, and it was perfect. We had a low average, we had tremendous variability, so this is just the kind of thing you want to go after. And this is the blueprint for something that you want to do quality improvement on, once you've established that the antenatal steroids really has a benefit, which was really quite clear. So we went after that. And we had terrific results, and from 1998, which was our baseline, to 2001, we made a really good improvement. So we were happy with that. But what really was exciting was looking at the 7 most challenged hospitals. And one of the things that I had to learn in quality improvement, and you probably have already learned it, is there are certain words that you don't use in quality improvement, like an ineffective hospital, or a bad hospital, or a poor performing hospital, or it's very hard to drop those words. But if you're going to be successful in Florida, you have to really, the idea is everybody wants to improve. No one wants to go, you go, what's the motivation? Well, part of the motivation is JCO, but part of the motivation is going to bed, and everybody can remember going to bed and saying, wow, what a great job we did on that kid or that mom. Things were so tough and everything just came together and it worked out. And you feel terrific on those, and I'm sure everybody can remember going to bed or saying to your partner, wow, what a day we had. This case came in and we just did everything. It was so wonderful. So what we're trying to do with quality improvement is make every day that kind of day where you really feel that you've done a fabulous job. And so here are these challenged hospitals, this word that I've taken so hard for me to get, people challenged because they would love to do a better job, but they just need the materials and et cetera to do that. Going 46% of eligibles up to 88, 50 up to 47. I mean, these are tremendous improvements showing that a formal program of quality improvement can really bring along the most challenged folks up into really wonderful areas. So we were very pleased with this. Now, one of the problems that we really faced was public disclosure. And we had decided that what we wanted to do in our public disclosure was to really say a group of hospitals, here is a group, got together. Initially, we were performing at this level, and after our quality improvement, we're performing at that level. And that's what we do. And when you read the textbooks on quality improvement, what you want to do is you want to increase the average, or if it's a bad kind of thing, decrease the average and decrease the variability. I mean, that's the whole idea. So here's the average, and you can see it goes from 80% up to 88%. And here's the variability, and you can see that there's a lot of variability, and we lower the variability. Not only do we lower the variability and increase the average, but this is the interquartile range. So that's if we line up all the kids that want to play basketball, 100 of them, you know, from the shortest to the tallest, and we go from kid 25 to 75. That's the interquartile range of our measurement. And you'll notice that the lower quartile cut point, which is 80, is now exactly at the initial mean. So we started off with an average of 80, and after the quality improvement program, we went up to 88. But now the lower quartile is exactly what was the mean at beginning. So this is a tremendous change, and you'll hear about this in quality improvement, but you really see this actually illustrated. So this is a fabulous slide because it illustrates what you read about but really see. So we're moving the median and we're decreasing the variability. It's exactly what you want to do. Well, this is terrific, and we felt really great about this. And then in 2010, as members of Vermont-Oxford, we looked at Vermont-Oxford and we saw that, gee, around the country, the medians didn't look so bad, but but look at the lower quartile, and the lower quartile is about 175 hospitals in this thing. So there are 175 hospitals that are performing like even at 26 weeks, where a kid really needs this stuff. Only averaging 69% of eligible moms are getting this. So this is really scary. So we decided we would look in California and see what's going on in California as well. And so here's in California, and even now, like what we've got is the upper quartile, the lower quartile, in the median. The median looks pretty good, around 2010 it looked pretty good at 81, but there were 64 facilities under the median, and 32 facilities were only less than 73% of the eligible moms were getting this stuff. So like we really wanted this didn't seem good to us, and we wondered what to start doing about this. And the first thing that we did is we wanted to ask the question, well, is it important to do this in California? And again, you always have the choice, do you use the literature or do you look at your own things? But we felt that because we had a toolkit and we were talking about it, that we needed some local kind of thing, and it's pretty easy for us to do data. So we did our own analysis between 2009, 2011, 15,000 neonates under 1,500 grams, and you look at this, like the mortality is really, really decreased. RDS, PDA, neck, which we didn't see much going on in neck. But look at what's down here. Here's intraventricular hemorrhage and severe IVH. And one of the things you have to remember is that when ligands, in the old days, RDS was a really big deal. But nowadays, RDS is not, we know how to do respirators and stuff. So thinking of antenatal steroids as preventing RDS and having a slight effect on chronic lung disease. It does protect against chronic lung disease, but not as much as RDS. These are kind of historical drivers, I think. The real advantage to giving this is not RDS. The real advantage is IVH, any IVH. I mean, these are kids with brain bleeds who are going to have a lot of problems. even in severe IVH. Look at the reduction in severe IVH. These kids are going to have learning difficulties. They're going to have all kinds of... This is antenatal steroids to go in California. We've got some places that are distinctly challenged, and we really have a problem with our outborn infants getting the appropriate levels of antenatal steroids. So once you know about this, that you have a problem, you know, you have to do something about it. And for us, the first thing to do something about it is to put together a toolkit. And this toolkit is available to everybody free. You can just go up. The toolkit used to come out, you could press one thing, you get the whole toolkit, and it's like, people complain because a lot of these toolkits are like 100 pages, 150 pages. And so what this is it's broken up so you can pull down what you need. And I actually pulled down the toolkit to read it, reread it before I came to see if there was anything interesting in it. And what was interesting was that I had to pull down all these little pieces, and then I was tired, I got them confused on my desk, but I got it together. And in doing this, I thought a lot about what's in a toolkit. So one of the things in the toolkit is the rationale, so you don't have to reinvent the rationale. So it tells you why you should be doing this. And this was important because when we started antenatal steroids, the idea was have a grand rounds with the OBs, present the rationale, present what's going on. So that's pretty heavy in this. So in a toolkit, the toolkit should present the rationale so that you can really present why this should be done. And there will be naysayers saying, well, what about this condition? What about that condition? And the toolkit covers those things so that rather than being derailed, you can actually address issues that might derail you. So you have both the rationale and kind of a synopsis of where you might get derailed. I guess that's a reasonable way to say it. So now you have the rationale, yeah, this is a good thing to do, we should really do this. The second thing it does in this toolkit, which won't apply, is it shows you how to go on to your database, the California database, to see where you are and how to drill down on this database to get more insight. But again, you know, looking at that example can help you in terms of the data that you might have access to and how you might do that. Because you know, if it's measured, it can be managed, but you have to be able to read the measurements. And sometimes these reports are not so easy to read. The next thing it does, which I think is really important, is to try to figure out where it is that, you know, what's the process to improve. So whenever you're doing quality improvement, one of the things you have to figure out is what you're actually doing. And oftentimes the difficulty is that what you're actually doing is not what you actually are doing, but what everybody is doing differently. So if you could figure, you know, if everybody was doing the same thing, you're light years ahead. What's happening is everybody's doing lots of different things. So one of the things that you have to do is you have to figure out what is this process that's going on and how is it being followed and what's the variability in this process. So in the toolkit, it really talks a lot about how you identify the process that's going on and how you identify certain change points in that process. And then it gives you a recommendation. So when you're thinking about quality improvement, there are a couple of things that you want to try to do. First of all, why do you need to know the process? Well, you need to know the process because that's what you're going to be changing. And if you don't know what the process it is, then you don't know what to change. And there are some strategies like the Toyota lean strategy where what you do is you really pin down that process. And then you look within that process and saying, where's the waste? Well, waste is when, a patient comes in, has all their labs, and you repeat all the labs. That's kind of waste. Waste is where you say, we're going to do a rule-out sepsis, and the cultures are negative, the kid looks great, and 6 days later the kid's still on antibiotics. That's kind of waste. So where's the waste in this process? And that's nice for your administrators, because administrators love to to get rid of waste. But it's also really good because it allows you to save money and time to put into other things that are really important. So the first thing you try to do is eliminate waste. The second thing you try to do is to eliminate variation. And it's been shown that even if you don't know the exact best thing to do, if you pick out what you think, well, we don't know, it could be A, it could be B, it could be C, they're kind of all look the same, there's not hard evidence, but if we all do A or B or C, if we all do the same process, even though it's potentially better but not really ironclad better, the mere fact that everybody's doing the same thing will reduce error, it will reduce confusion, and it will give you a better outcome just because everybody is doing the same thing. And you could think, like any process, even any process, if you're doing it the same way, everybody's familiar with the same way. So if someone writes the wrong dose, you pick it up. If someone is really lagging behind and hasn't written the order and it's supposed to be written, it gets written. So this idea of standardized workflow, even if the workflow is not exactly the optimum, will always benefit the patient. Will always benefit the patient. And then the third thing, so we're eliminating waste, we're getting a standardized workflow, and then the third thing is we're trying to adopt better practices. Better practices. So those are the things that are kind of covered in this in the toolkit. And the toolkit is neat because it gives you examples of one of the things that you have to do is how do you figure out the process? How do you audit the process? How do you write new orders to make antenatal steroids easy to do? And all of these examples are given in the toolkits. And you may not want to do exactly what the examples show, but it's enough of a starting point so that you, rather than inventing from scratch, you can spend the time debating how you want to change the recommendation. So people don't usually talk about toolkit construction, but I think it's very important to know what's in a toolkit. So how to get started? This afternoon we'll talk about a couple of other things, but I like the fishbone diagram because it looks at all the possible contributions to doing something or not doing something. You look at the procedures, the equipment, the materials, environment, people, miscellaneous. I have to tell you that antenatal steroids is relatively straightforward. When you're talking our toolkit on hemorrhage, that's really difficult because then you have to figure out how to measure hemorrhage because people aren't measuring it correctly. That's one of the major things is that you don't anticipate, you don't really realize how much the woman is hemorrhaged. So you got to do that piece. Then you've got to get the blood around, and so there's this whole blood thing piece. Then once you have the blood around, so once you have the materials in place, once you have the diagnosis in place and the materials in place, then you have to have a response team in place. So some quality improvement is very complex and some is less complex. And I think antenatal steroids is an example of a fairly less complex. It's a good place to start. It's a really good place to start. In the neat thing about it is that the gains are just enormous in terms of the baby. So anyway, this is a fish diagram. This is from ours, and the idea is you start to circle things that you're concerned about and write in things that aren't on this, and that's kind of an important way to get started. So rationale for perinatal approach. Neonatal outcomes are heavily dependent on prenatal and perinatal factors. Neonatal input can help optimize the outcomes for both mother and infant. And common goals of obstetrics and neonatology can be facilitated by close collaboration. This is just a reiteration of what we said before. Now, it was really interesting that when Dr. Sappenfield actually asked me to do this, he really wanted me to talk about antenatal steroids as a collaborative effort. And it's interesting that in 1990, Liggins, who discovered the antenatal steroids, was really upset because here, there were so many randomized clinical trials, so much talk, and no action. So he wrote this commentary on obstetric and pediatric collaboration to reduce morbidity after preterm birth. And it's just really terrific that you read, that the idea is that obstetricians are doing it, but neonatologists really have a profound investment in this, and you have to work together as a team to make sure that it happens. So it's really a terrific little article, and he's just dismayed that it hasn't caught on. I mean, it's just, he just can't understand it. And I think that this is old quality improvement. I think quality improvement is going to get a huge leap forward, especially when organizations like JCAHO start to take quality improvement seriously and say, these are things that we can do well, that they really make a huge impact, and if you don't do well, you really should be held accountable for not doing what everybody could do well and make a terrific impact. So here's I guess this is like a final slide, what's going on in California. Well, we're trying to look at, in California, as perinatal medicine as a collaboration. And we have like 3 organizations that are brother-sister organizations, I guess. And one is CMQCC, which is obstetrics. We really need an obstetric organization because we have 290 obstetrical sites that improving overall obstetrical care requires looking at conditions that are different from the NICU kind of conditions. So it makes really good sense. We're looking at toxemia. We're looking at, of course, antenatal steroids. We're looking at toxemia. We're looking at hemorrhage. All of these impact on the neonate. One of the things that we're doing is that in our neonatal database, which is recording now on, I think, 132 NICUs are in this, California NICUs are in this. We've just modified the neonatal database to be JCAHO compliant. So we've, for our small babies, we're now up to 32 weeks, and we now have a question on whether there's documentation. And the reason for this is that we're going to start feeding some of our neonatal information onto the obstetric reports, and some of the obstetric report stuff gets fed onto us, so that we're really trying to use. My wife's a psychologist. I love structural interventions. I think structural interventions are what make things really work. So the fact that we're feeding them data and they're feeding us data just has to start conversations between the two groups. One of the problems that we have in neonatology is that we really hand off the baby to the pediatrician, and when I'm on service, if it's not busy, I call them up and I give them a whole discussion of what that baby's going to look like and the needs. And when I'm really busy, that doesn't always happen. We also have in California a high-risk infant follow-up program. It's terribly underutilized. It's paid for by the state. We're seeing about 6,000 infants from the NICU, and that has a database also. And of that database, we've just created a NICU-level database so that neonatologists can now go on and look at the outcomes of their infants. But it's much more important than that, because the database not only gives outcomes, but it gives all the needs. Like, so oftentimes you'll have a baby with severe RDS, a bronchopulmonary dysplasia, or chronic lung disease. You have no idea what that baby, you know. So now you can go and you can see what are the rehospitalizations, what are the total spectrum of services that that baby's getting, what are the medications that baby's on, up to 3 years. So again, we're hoping that providing data on outcomes and resource needs and utilizations, and whether the baby's getting what the baby should be getting, is going to start to close this gap between the neos and the pediatricians and the developmental follow-up. So that's what's going on in California. As I say, California's a big state. We have 550,000 births a year, 290 delivery sites, 132 NICUs, and I think 60 high-risk infant follow-up clinics. So there's a lot going on. So effective quality improvement requires data and a team built upon proximity to the issue. And one of the things that we found, again, is that it's very important to have everybody who's proximate to the issue involved. So, you know, if you have only your if you have only your obstetricians and your neonatologists sitting at the table to do your antenatal steroids, it's not going to work. You know, you need your delivery room nurses, you need everybody who's involved, everyone who touches that patient. And even the ward clerk can be important, because maybe part of the waste is that it gets written, but then the ward clerk doesn't send the request down to the pharmacy, or so everybody has to be involved in looking at who exactly is proximate to the issue. It's also important because all of a sudden these people that get left out because of the hierarchy of medicine become part of the team, that all of a sudden the ward clerk is important, the charge nurse is important to the neonatologist, that people who are seen as servants, you know, are really seen as essential members, and people start to talk up, you know, in a high reliability organization. One of the things that you're trying to do is to get teams to talk to each other and break down hierarchies. And I can tell you, if you want a high reliability organization, the structural intervention to do that is a quality improvement collaborative that includes everybody who's who's proximate to the issue. You get all those folks together and get them to look at the California thing, and do you like this toolkit? Is it bogus? Are there stuff that applies to you? How can you get it better? And you get everybody involved in that, and all of a sudden you look around the room and people are talking to each other. That the ward clerk is making a comment, that the nurse is making a comment, the respirator, you know, whoever's involved are starting to talk. People are listening. Oh, that's a good comment. You know, oh, you have something to add. And it really changes the flavor of things. And when you go into organizations that are serious about quality improvement, you start to see that the interpersonal relationships between members of the team are really quite different. You know, that the mutual respect has just really built up. So I think quality improvement is important not only for the patient, but for those of us who work in a place. We want to work in an environment that's really fun to go to. We want to work in a place where we really can talk to our colleagues and get, you know, job satisfaction. And so we're not just doing this for our patients, we're doing it for ourselves. We really are. You know, that to have really good quality improvement, it not only improves the quality of care, but improves the quality of the workspace. So it's important. Plus, you can go to bed feeling you've done a great job. So the final slide here. Whoops, there was supposed to be a final slide. I don't know how to go down. The final slide says, oh gosh. Okay, and now we go to the,
No, let's do it differently. There could be an easier way to do this.
we're going to go to the final slide. What does the final slide say? You probably have all figured it out by this time. We can just go down.
I got to go all the way down. Yep. That is your final slide.
Okay, the final slide, which is left off, but I have it. But, oh my God, it's left off here also. The final slide would say that quality improvement is possible. All it takes is creativity and commitment. So I'll leave with that and try to answer questions.
So we have time for just a couple of questions. Questions from the audience? Please remember to use that black button in front so people can hear you. No questions.
I think I wore everybody out.
No question, but comment. Thank you so much for all of your work. I can't imagine doing this work without all the work that you've done. So it's amazing. Thank you.
Well, thank you very much.
Let me ask a question. We got a chance to hear from Ohio, who's just been trying to do such an initiative in the last month, about a month ago. And what they're discovering is more of their problem, Jeff, is reporting than practice. Ideas of California, do you really have those people who are not practicing it, or is it really a reporting issue?
Well, I think I think reporting is a really big issue. You'll probably hear tomorrow, but I think that the difference was something like between 45% and 90%. It was a monster difference. Reporting is really important, and as we start to really do quality improvement, one of the things that we have to think about is reporting. Especially if you start to use vital records, you've got to improve your vital records. If you start to use ICD-9 codes, you have to improve that. And as we move to the medical record, the challenge is we've got to start teaching nurses and physicians that when you check something on the electronic medical record, you have to really know what the definition of that something is, because you can't go to a paper record anymore. The only thing that's left is that checkbox. So if you don't really understand the definition for that checkbox, we're really awash. So I think that the next decade, as we start to really work on this, is going to be really paying great attention to our definitions and our reporting. So that's kind of...
Well, Jeff is going to come back this afternoon and talk about sustaining, but we wanted to thank him early. Here's a present and a card.